the permission of the chair, thank you very much for having me here. I come from Kashmir, a very cold area, and the incidence of chronic dacrocystitis and nasolacrimal duct blockage is quite massive. So a resident would start with learning surgery from a DCR and a DCT, and on an average practitioner would be doing around 6 to 10 DCRs in a month. So this is an idea of intubation and manipulation in all cases of dacrocystorhinostomy. So this is a 20-year-old retrospective study, 1998 to 2019, and we selected uncomplicated nasolacrimal duct blocks. That is, those people who had a good punctum, who had patent canaliculus, who had no recurrent acute attacks, and who had no gross nasal pathology. And what we did was that we picked up only those cases which had uncomplicated surgery. That means during the surgery, you had good hemostasis and the clear anatomy and identification of structures. You didn't have any problem there. And then there was a taut end-to-end anastomosis at the sac and the mucosal flaps. Our usual way is to actually cut the posterior flaps and suture only the anterior flaps. And over a period of time, we were doing an external approach DCR generally. Then we shifted on to external approach DCRs with silicone tube intubations as better silicone tubes were available. Then we started doing them with silicone tube intubation. And finally, the external approach DCR with silicone intubation was, again, another step was added, that there was manipulation done in the earlier stages. So what did we classify as successful DCR was an asymptomatic follow-up for 1 year. Many patients would report after 2 years or 3 years, but minimum we followed them up for 1 year. And then we were trying to assess the difference between the success rate of these approaches. So we know that the drainage path is that of 3 compartments joined together by 2 resistance small openings. And in NLD block, we know that the fluid cannot move down. So in dacrocystorhinostomy, we are creating a model of a 2-compartment system where the fluid is flowing directly into the nasal passages from the cul-de-sac. So what did we think over a period of time? What were the causes of an uneventful DCR failing? One is that you're not using the right instruments, or you're not dilating the punctum well while you're doing surgery. So there's possibility of a punctal stenosis. Simple things which we tend to disregard. Another thing is a common canalicular block. While the canaliculus is being intubated, you're putting in a probe, you're causing small injuries to the mucosa, and those finally land up in canalicular blocks. And a common canalicular block, and then fibrosis at the site of the anastomosis. This fibrosis may be incited by excessive blood or clots staying there, or from outside the area. So we decided that we will try primary intubation of all cases and then check the results between the two. And once this is done, you can see that this is a small video of showing the intubation. And it's very critical in a study like this, where we are comparing different things, that the surgeries overall have to be comparable. You cannot be comparing a difficult surgery with intubation with a simple surgery without intubation. So most of the surgeries were done by me or my experienced senior residents, but most of the surgery was done by people who had experience in DCR of more than 5 years. And another thing that's important while you are intubating is that you have a better concept of the openings, because these tubes come out at one place, you know where you're going, and generally speaking, identification of anatomy should not be very difficult as such, also in the hands of an experienced surgeon. But important is that a good DCR whether we're doing a DCR with intubation, or DCR with intubation and manipulation, the primary thing and the most important thing is a good DCR. And once that is done, then we know that these results can easily be compared. So after that, we manipulate this tube. In the third group, we manipulate the tube at first weeks. A lot of clots might come out, and patient might feel a little difficulty. Sometimes there's a small amount of ooze. Then you do it again at second week, and then you do it fourth week, sixth week, and on the sixth week you remove the silicone tube, because finally you don't feel that there's any need of the silicone tube after that. So what have we practically done? We have removed the chances of a punctal stenosis after the surgery, because there's a tube there, and any trauma you've caused to the small opening while doing surgery, that's negated. Then you also don't have chances of a canalicular block or a common canalicular block. And while you are manipulating this tube in the first, second, fourth, and sixth week, what you're doing is that you are here removing any fibrin or blood which might incite fibrosis, because we know what the factors for inciting fibrosis are. So what did we see? We saw a significant difference in the success rate of the external approach DCR with silicone tube and the silicone tube manipulation. And we believe that this decrease was that it causes the chances of punctal stenosis and canalicular blocks. And if you manipulate it, it brings it further down because it causes early manipulation. It fragments the clots which might incite the fibrosis. So these are other studies which are showing the success rate. I should have shown the failure rate. This is the success rate. So my conclusion was, and my experience with 20 years, actually 22 years of doing DCRs in our sort of setup, was to intubate and manipulate, and for 2-minute manipulations make it almost infallible. Thank you for your kind attention.
There is a chances of canalicular tear.
Yeah.
So this tube, at the end of the surgery, multiple knots are placed here. It's a slightly looser. The length of the tube outside the nose, it almost comes to the lip. And there are multiple knots, because otherwise it might actually slip away. Multiple knots, and these are actually pushed inside the nose. So patient does not even have cosmetic problems of a tube lying there. So unless this is tight and it has been, the knots are up there, the chances, we have almost never seen, except for redo DCRs and DCRs in which there were canalicular blocks and we were trying to negotiate through those blocks. We have not seen in these primary intubations any complication of that sort. Yes, sir. Mike, please.
Success rate of primary external DCR even without intubation is very high, maybe 95 to 100%.
Yes, sir.
And most of the experienced lacrimal surgeons, they say intubation in a primary DCR is most likely unnecessary. It is not required, and it is too much to do in all cases. Just to help, if couple of cases out of 100, say, which may be having common canalicular block or stenosis, in those cases it may help, as you are saying. But for those 2 cases out of 100, you cannot victimize 98 cases which will be successful with a primary external DCR in experienced hands. This is my first thing. And second is, this is not working here. Hello. This is also, hello. Second is, you don't have any controls also. You
No,
don't
sir.
have any controls.
Yeah, yeah.
So without control, you can't comment, no?
Yeah, sir. The only perhaps
And
there is a control.
other valid apprehensions which
Yeah.
Dr. Moria and Dr. Khare has said, damage to canaliculi and the discomfort of a long silicone stent in the nose harboring at least for 2 months, as you said.
Yeah. Sir, 2-3 submissions. One is that we do know that the possibility of punctal stenosis after a DCR is real. Many of these patients have undergone repeated syringings.
Yeah, I agree for that, but for
yeah.
that, you should do a good pre-operative workup of the case. And you know that this is a case you are dealing with common canalicular stenosis or block.
Agree.
This is a case where you have punctal block. In these cases, you will tell the patient that these are the things, and you will do accordingly.
Yeah.
But
so
if you are not doing good pre-operative workup and giving this blanket treatment to all the cases, to my mind, it is unnecessary.
Sure. So we also.
Not using this intubation in all cases. We first assess and then if it is there a canalicular block.
Sir, to start with, sir, I said that this study has been done. We excluded cases which were difficult. We excluded cases which had a canalicular or this block. Yeah, yeah.
The intubation in primary external DCR is indicated only in those cases where there is bleeding, where there is problem in flap formation,
Right.
where junior person is doing. So all those things where you encountered CC block at the table.
Right. No, these patients did not have that. Sir, my only humble submission is, how does that tube increase the success rate? If we have a difficult case, or how does it improve the success rate of that procedure? What happens around the silicone tube?
It doesn't improve the success rate.
So here, a very, very simple idea that there are 2-3 possible complications which might occur, which can be prevented. Thank you very much, sir.